I think the main take-home message for community oncologists is to refer patients for these treatments at the appropriate time, and not to wait until patients have failed every known therapy known to mankind. Really, these treatments that use your immune system, I think, work better when you have less disease generally, and have disease that's less mutagenic and less beat up from prior chemotherapy. So I think the results are only going to get better as we move these studies earlier in patients' course. Of course, they have to start in relapsed refractory patients, but they're going to rapidly move forward. The next trials in lymphoma are going to be comparing against auto transplant. The next trials in leukemia are going to even be trying to not give all the chemotherapy with induction, so in high-risk patients. So I think we'll move them up, and so it's really important for people to think about these new treatments, before last-ditch efforts, and actually try to refer them to centers that can do them. But it's going to be a while before some of these things, like CAR T cells, are going to be in the community oncologist centers. I mean, I think it would be the worst thing in the field to try to immediately bring these out to centers that have no experience. You really need it. There's a learning curve, and you need to learn how to manage these patients. And so for now, think of it like a transplant. Refer those patients to likely the transplant centers where most of these studies will be done, at least for CARs. The other ones are being done, obviously, in a lot of community centers. You just need an expert leukemia division and a good ICU and good clinical care.